Today we're going to talk about the liver, okay? So, we deal with a lot of patients with liver cirrhosis, so obviously the boards also loves questions about liver cirrhosis and the problems that happen with the liver, right? So, let's talk about what causes liver cirrhosis. What are some of the causes we need to know about?
Alcohol.
Alcohol, obviously the first big one, okay? What else?
Virus.
Virus, which is all of your hepatitis, right? Okay, what else?
Cancer.
Well,
You can't get cancer from the cirrhosis.
yeah, you'll end up getting more cancer. If somebody's got liver cirrhosis, they're at a risk of getting liver cancer, right? That's why you screen them to see if they're getting liver cancer, but not necessarily go the other way around, right? So what else? Huh? Is it called NASH now or is it called something else? It used to be called NASH, now it's MAFLD, and now it's MASH instead of NASH, right? I think this name change actually makes sense. Because saying something is non-alcoholic is not telling you what it is due to. This is metabolic associated steatohepatitis, meaning the patient's got diabetes, hypertriglyceridemia, obesity. Those metabolic disturbances are what's causing the liver cirrhosis. So it makes more sense, the name change. Okay, what else? Huh? Well, alcohol typically will lead to fatty liver first and then cirrhosis. Huh?
Cardiac issues.
Okay, if somebody's got, CHF because of back pressure, it can cause. There are a lot of other causes still. What are causes?
Nephrotic.
So, autoimmune, yes. Okay, very good. Yes, drugs, right? And your big drug that we need to know about is what? Acetaminophen, right? Okay. Acetaminophen. What else? Yeah, a lot of chemotherapy drugs can cause, including methotrexate, can cause liver cirrhosis, and even statins can cause hepatitis and whatnot, right? What are some other big causes?
Radiation.
Huh? Radiation, not so much, huh?
About drugs or just
Other condition that leads to liver cirrhosis. Two big ones you guys are still missing.
Primary biliary.
Well, primary biliary cholangitis, yes, it can also cause, right? So primary biliary cholangitis or primary sclerosing cholangitis, they can all lead to liver cirrhosis. Yes. Hemochromatosis is a big one, right? Good. Hemochromatosis. Okay, what else?
Wilson.
Huh?
Wilson.
Wilson's disease, yes. And then somebody said autoimmune already, right? Okay, so these are some of the main causes why somebody would end up with liver cirrhosis. Now, once the liver cirrhosis happens, there's going to be a lot of problems that's going to happen in your patient that we need to know in the clinical practice, but also in the questions. So let's start from head and work our way down, okay? So number one, patients are typically going to come with altered mental status when you have liver cirrhosis. Why? Well, hyponatremia can happen, yes, but ammonia. So what we're going to call this is hepatic encephalopathy due to elevation of ammonia, right? Why does the ammonia go up? Because you don't detoxify. Ammonia is typically detoxified by the liver, so if you don't detoxify it, your ammonia is going to go up. And then when the ammonia goes up, you become encephalopathic. Now when you say encephalopathic, patient is not hyper-responsive. They are very comatose and sluggish, and that's how they're going to be, right? So it's more suppressed feeling. But could you have a patient with hyperammonemia presenting with seizures?
Yes.
It goes against my theory, right? Because I'm saying it suppresses you, doesn't overexcite you. But hyperammonemia can cause seizures too. Okay? So that's important to know. So when somebody's got hepatic encephalopathy, you can diagnose them and you get an ammonia. It's elevated. You got your answer. How are you going to treat them? Very good. So you can have something called hepatopulmonary syndrome, right? What is hepatopulmonary syndrome? It's essentially because you're developing portal hypertension. But what is very unique about somebody who will come with hepatopulmonary syndrome? What are they going to have?
The opposite of orthopnea.
Yes, they'll have the opposite of orthopnea, which is known as orthodexia platypnea. Okay? Orthodexia platypnea. Okay? What does that mean? So when you're going, typically most people are short of breath when they're lying down. Right? When they sit up, they feel better. Here the opposite is going to happen. So whenever they are lying down, they feel they can breathe better. When they sit up, they feel more short of breath. Why does it happen?
Because they are shunting blood.
Yes, because they actually have AB malformations that actually favor blood flow from the arterial to the venous circulation that is forced when you're actually sitting up. Okay, so that's the reason, because of the AV malformation, that you end up with orthodexia platypnea. Where else do you look for AV malformations?
GI.
Yes, but in the sense of instead of hepatopulmonary syndrome, okay, instead of hepatopulmonary syndrome, when else would you look for an AV malformation in your lung? What if somebody had a stroke? Okay, somebody had a stroke, it looks embolic in nature. You get a bubble study, which we always do on all our patients, right? And there was no bubble, there's no PFO or ASD on your echocardiogram, right? But the patient's got embolic stroke in the brain, no other cause found. Can you look for something else that can potentially have AV malformations, shunting and causing strokes? What else can happen? What happens to blood pressure in patients with liver cirrhosis? They become hypotensive. There's a famous saying liver cirrhosis cures hypertension, right? Why does it happen? Vasodilation, because your liver is supposed to do a lot of things, right? But it doesn't metabolize everything. You have a lot of nitric oxide that's going to be roaming around your blood, and nitric oxide, we already know, causes vasodilation. So vasodilation and hypotension becomes an important thing. When it comes to liver cirrhosis, what do you want your MAP to be?
82.
82% and above, right? You want it to be MAP greater than 82. What else is going to happen? Anybody who's diagnosed with cirrhosis, like right now, what do you need to do on those patients?
EGD.
You have to do a screening EGD, very good, because what are you looking for? Varices. And why does varices happen? Because of portal hypertension, right? So portal hypertension is what you're going to be looking for, right? Now, whenever you suspect somebody's got portal hypertension, say you do an EGD and see varices, right? What are you going to start those patients on for treatment of portal hypertension?
Not bleeding.
Huh?
Not bleeding.
Not bleeding. You're just screening and patient has portal.
Prophylactic.
So you want to do beta blockers. Do you want to do selective or non-selective? You want to do non-selective beta blockers. What are the famous beta blockers we've always used here? We have always used nadolol, okay, and propranolol, okay, propranolol. But is there a new drug now that is more favored apart than this? It is carvedilol. Yes. Why? Because it has alpha blockade. The end of the day, when somebody's got portal hypertension, why is it happening? You have your portal vein formation, right? You got superior mesenteric vein, splenic vein, which joins together to form portal vein. So when you have a lot of pressures here, that's what's causing portal hypertension. You, by vasodilating these vessels, you're dropping portal pressures. So carvedilol is in fact going to be your first line. Now, but I'm going to come up with a very important caveat here, okay? Let's for instance say a patient comes with ascites, okay? Belly is full, patient's got ascites, and patient looks fluid overloaded, okay? New patient, we have never seen anything about him before. What do we assume first off? He's fluid overloaded. What could it be because of? It either could be heart, liver cirrhosis, or nephrotic syndrome. Okay, you're going to get some fluid from the ascitic fluid, and the ascitic fluid you're going to do a SAG, right? Which is what? Serum albumin ascitic gradient, right? So typically your number needs to be greater than 1.1. We'll call it portal hypertension, right? Now remember, this is not division, subtraction, okay? You are subtracting, not dividing, okay? So if it's greater than 1.1, let me ask you this. In liver cirrhosis, what would happen to SAG? Greater or less? It'll be greater. It's portal hypertension, right?
Yeah.
So it'll be greater than 1.1. What about heart?
Also.
It is also going to be, because why? Your heart is up here. If nothing's going to drain into your heart, it's back pressure essentially causing portal hypertension too, right? So it's going to be greater than 1.1. So how would you differentiate the two?
Protein.
You will get total protein. You get total protein from your ascitic fluid, and your magic number here is 2.5 grams, okay? Who produces protein? Liver. So if you have liver cirrhosis, it will be less than 2.5. If it's good CHF, your liver is fine in that sense from the production standpoint. Therefore, your protein is going to be greater than 2.5. It's super important that you make that delineation, okay? Why do I say that? Say for instance, if somebody's got liver cirrhosis, okay, there's compensated versus decompensated. Decompensated is anybody with any symptom of liver cirrhosis. May it be jaundice, may it be hepatic encephalopathy, may it be ascites, right? All of these symptoms means the patient is decompensated. What is the number one rule when it comes to managing a liver cirrhotic with fluid overload? Do you fluid restrict or sodium restrict?